So there is a hot topic, which is, if I understand well, on physiology today. And Bharat from Singapore will present it. So Bharat, please go ahead.
Okay, thank you, Prof. Cortese. So I'll, if you can allow me to share the screen.
Got it.
Okay, so sorry, it's the wrong talk.
Quo Vadimus.
So I thought because we have Felipe with us today, it's probably nice to incorporate some Latin into my presentation. So I thought, for those of you who don't speak the language or don't understand the language, Sarah basically asked me to talk about physiology-guided non-culprit PCI in STEMI and acute coronary syndrome. It's quite a hot topic, particularly over the last 12, 24 months. But I really want to discuss where we are going. And so Quo Vadimus, I guess, is the Latin for that.
Yeah, pretty nice.
The idea is really to try and keep this a bit interactive. We'll go through a couple of cases, and then we can talk about data and what the guidelines recommend. And I'm happy to be interrupted at any time. I will pick on some of you as well, because Sarah wanted me to keep this as interactive as possible.
Yeah, we have to. We have to. But you know, it's. I'm happy to do that. You know, also in a normal, I would say, lesson.
Yes, so we're going to deviate a little bit from one person talking to more 5 or 6 people talking today.
So there should be also a counterpart, no? Usually.
Yeah, there wasn't anyone sort of allocated today, but maybe as a group, someone wants to, just comment or anything as we go through. Okay, so the first case, 79-year-old man, hypertension, hyperlipid smoker. He came in with delayed anterior MI. He had a bedside echo, which showed moderate systolic dysfunction, and his troponin was already 15,000. So this was his angiogram when I took him to the cath lab. You can see an occluded proximal LAD. Lots of thrombus there. The circumflex, there is a sort of CTO of the circumflex OM system just after the principal OM or OM1. And then his right coronary artery has, it's quite ectatic, it's large. There is this sort of taper in the mid vessel just where the RV marginal comes off. And so we decided, because it was anterior MI, he had chest pain, we decided to proceed with primary PCI. Now, this was quite challenging. We had to utilize quite a few different strategies and tools, but in the end, quite a nice result. Stent to the ostium, single stent, post-dilated, and optimized on IVUS. So what about the non-culprit artery? And maybe I'll ask for some volunteers. Would anyone fix the RCA now? Go on and fix the RCA?
No, I wouldn't. Normally, I don't fix non-culprit at the same time.
Yeah, at the same time. Would you stage it?
Yeah, definitely I would stage it. The current guidelines says that you have to offer a total revasc unless the patient has got other significant frailty, comorbidities, in which case I would go for a symptom-guided PCI. But yes, I would definitely do it. The only question obviously here is, I know you're talking about physiology. Slight caveat of physiology here, the RCA feeds collaterals to the blocked circ. I think one you see some collaterals. So if you do assess the RCA with a pressure wire, you may get a result which may be difficult to interpret because it feeds the collaterals. So here I would probably just go with the angiograph appearance of the RCA first.
Yeah, I think that's a very good.
Can you come back to the angio of the RCA? Just to see it again, yeah. So I think that one of the most important things when we have to decide if to treat that or not, I agree with the Sandeep that I wouldn't do that in the same setting. But there are several things that we should take into account, in my opinion. Among these, of course, comorbidities. Can you mute your? Who is doing this mess? Okay. So it will be important, of course, comorbidities. We have to have more information about the echo, the function, and of that vessel, and also the viability, if it's vital or not. But there is also another thing that is usually outside of the algorithms, which is how complex is to deal with that lesion. Because one thing is to go for a simple PCI in a non-culprit vessel. You can decide same setting or in another one, whatever. But if the vessel, the lesion treatment is complex and the risk of complication is higher, you have also to consider that before taking the decision.
Yeah, some very great, good points there. And I think, so number one is, should we fix or not? Number two is, if we do fix, do we need to do physiology, or are we happy to just go by angio guided? And number three is, if you do use physiology, which method of physiology would you rely on? I think, like Sandeep pointed out, the FFR does take into account the collaterals. So you may have a falsely low FFR, particularly if you have collaterals, and the lesion may not be as significant as you think. But with the spot IFR, usually they say that the spot IFR is probably better when you have collaterals, because it gives you the sort of hemodynamic assessment of a particular point, rather than to take into account the distal microcirculation. So that is all considerations. And then finally, timing of the intervention. So when do you do it? And as we go on throughout this talk, we will talk a little bit more about that. So I think the majority of us agree that we would probably treat the RCA. Some of us may or may not use physiology. And then in terms of when to treat, I think most of us in the context of an MI like this, a big anterior MI, will probably defer from treating in the same procedure. Who would treat in the same hospitalization before the patient goes home? Maybe 1 or 2 days?
Yeah, I would do that. After, see how is the outcome of the first PCI, since
if it recovers well,
the latecomer STEMI, yes, can have some complications. So yeah, let's see that. Let's see the creatinine. Let's see all of that, and then I would try to do it after 3 days, 3 or 4 days.
You see, if you had asked me this, sorry. No, if you had asked me this question before the pandemic, a lot of the time we used to bring them back in 6 to 8 weeks time and do it. But now the problem in our setup in the whole UK is the waiting list is so high, it's very unpredictable. So with that in mind, I always do the inpatient stage procedure before they go home. Unless, as I said, there are this is a very important lesion in the RCA. Yeah. So in the past, I used to do them in 6 to 8 weeks time.
Yeah. Big dominant RCA. So I think if you're limited by your next appointment being 3 to 6 months, and you're not able to do it within a few weeks, then I think, doing it during the same hospitalization prior to going home. What about the circumflex OMCTO? Would anyone tackle that?
I wanted to understand first by Vakas and also Filippo and who is there? And
thank you very much.
Hello.
Hello, how are you? This is what I am thinking, that this is a late presentation of acute anterior MI. Because once we are having a late presentation of acute anterior MI, then a clot is somewhat organized, and we are not usually getting the no reflow or slow reflow phenomena while doing the PCI. So I suggest to do this RCA within the same hospital admission rather than doing in the next 45 days. Number one. After getting the RCA, I will definitely, there are 2 approaches. We will check the thallium with ischemic burden. We will check the ischemic burden. According to ischemic burden, we will proceed for the PCI to circumflex, but this is having a blunt proximal cap. So technically, this is a difficult PCI, CTO PCI.
Okay, Wojciech and Filippo.
If the FFR is negative, will you consider the intravascular imaging or CT, for example? And what's going on? What could be your decision if there could be then what do you recommend in such situation when we right now know that we could have higher risk of adverse events during the follow-up, and if there is for example a high plaque burden and or some vulnerable plaque features, and how to treat it, DTB or DS?
Yeah, so some good points about how to treat it. Circumflex OM, anyone would do that?
I would not do that in the same hospitalization. Probably I would postpone it after a couple of months.
Yeah.
Yeah,
But
maybe
if you-
taking into account patient symptoms and also myocardial ischemia with maybe
Yeah.
a myocardial scintigraphy.
Yeah, so I think
And
most of us
regarding
would,
the RCA,
I think most of us
you
would
can-
do RCA, and then the circumflex, we would either depend on symptoms or some sort of demonstration of ischemia. I think we're all on pretty similar page with regards to that.
Yeah.
Okay, the second case, 62-year-old male. His father had a MI in his 60s. He's a non-smoker, no other medical history, and he came in with chest pain. And this was his ECG at the time of his presentation. So quite clear sort of inferior MI. So this was his left coronary system. I tend to, particularly if it's inferior, I use the Ikari guides and do a quick shot of the left before I swing over to the right if I'm radial. And you can see the collaterals going to the RCA there. There is this moderate lesion in the LAD, but it's not, doesn't look critical, but just something to take note of. And this was his RCA. So primary PCI, single stent, good result. What about the LAD? Would anyone do the LAD here?
Could you show us the LAD, please?
This is a typical case of a study we are participating, which is iModern. You have a culprit STEMI and then a
Fantastic.
non-culprit. Yeah, and in this study, this LAD is, we do the randomization after primary PCI, and randomization is between MRI in day 2 to 6 after the primary PCI or immediate FFR. So it's still a
MRI looking, it's an MRI perfusion, is it?
Yeah.
Yeah, MRI perfusion. Okay. So would anyone fix this this LAD?
I have one more question as a part of discussion. This is LAD is a non-culprit vessel. So during this primary PCI, after fixing the RC, can we go for FFR in the LAD to look for during the same setting?
Good question. Can we?
Yeah.
Is it reliable? Wojciech, is it reliable to do the FFI and non-culprit?
At the same stage. I think that STEMI, the inferior ward, the RCA was occluded. We should wait some days and perform the FFR of the LAD. Is my opinion. Or other possibility in such patient, we can also perform the SPECT in such case.
Yeah, as an outpatient, and then decide about revascularization. So no one would think angiographically this is significant and we should stage a PCI during the hospitalization. Everyone thinks that needs some sort of more information. Is that
Bharat, I would have been more aggressive until a few years ago, I have to say. 62-year-old male, I would go for DCB PCI, no, at least high.
Yeah,
but it depends.
Literature is changing, so you don't know if how much is the vasoconstrictor tone during a STEMI. So probably I would schedule another, either a CT scan after 2 or 3 days or another coronary angiography, more probably,
Fantastic.
then decide.
I like everything you're saying. It's all very, it leads on to my next slide. So that's very nice. Okay. So some of us may treat, some of us may not treat, some of us would like more information before we treat. So what do we do here? So number one question is, what is the data for complete versus culprit only PCI? So I think most of us are pretty happy that the evidence base does support complete revascularization, particularly for disease, for non-CTO, for relatively straightforward disease. And lots of trials have actually looked at this. So when we look at STEMI patients and looking at the non-culprit disease, there have been many trials across the last few years looking at this. The largest one, of course, and the one that most of you must be familiar with, is the complete trial. And really, all of these trials showed that there was a benefit with complete revascularization. So these are all randomized controlled trials. And when you actually look at the definition of significant stenosis, the majority of them actually consider, if it's more than 50%, it's considered a significant stenosis. So in the previous case, it was probably around 50% and it would have been included in these studies. Now, some of the studies actually use physiology if it's between 50 and 70%, and angio-guided only if it's more than 70%. But we'll go into some of that in a bit more detail. So we're all familiar with the complete trial, more than 4,000 patients, looking at new MI and cardiovascular mortality, as well as ischemia-driven revascularization. And really, this showed that there was reduced primary outcome, both the primary and the co-primary, with complete revascularization. 4,041 patients showing that complete revascularization was better. More recently, there's been a meta-analysis looking at this and really concluding very similar. No change, no significance with all-cause mortality, but reinfarction, cardiovascular mortality, and repeat revasc all lower in the complete revasc group. So complete revascularization better. So what is the answer for question one? The evidence does support it, that complete revascularization is better. And a little note here is that non-culprit is more than 50%. So it brings us to question number two. Is physiology in STEMI reliable? So I think Wakas mentioned earlier, is the pressure wire in the non-culprit vessel actually reliable? And number two, is it required or recommended? So when we all know that in STEMI, what you actually have is, like Professor Cortese said, we have high adrenergic tone, high LVEDP, high heart rates, low blood pressure, microvascular stunning. You can get this reduction in the ability to get maximal hyperemia. And so you tend to get smaller gradients and higher FFR across any given stenosis. And this really refers to just the culprit vessel. So in the culprit vessel, because the microcirculation that's been supplied by that is affected, the FFR is usually not reliable. And this little this trial over here actually looked at this, and they looked at comparing IVUS parameters between AMI and angina in culprit vessels. And on IVUS, there was no statistical significance between luminal area, mean luminal area, and stenosis. But when you did pressure wire, in the AMI group, it was always higher, so artificially higher. And then if you stented these patients and they had TIMI 3 versus TIMI 2 flow, again, there was a difference in the FFR. So really, this shows that the FFR is overestimated or unreliable in the culprit vessel in STEMI. So really, we shouldn't be using it in the culprit. But what about the non-culprit? And this was quite a neat study where they actually looked at the microvascular resistance. We know that FFR is incorporating the microvascular resistance, and they looked at the non-culprit vessels and showed that in STEMI patients, the microvascular resistance in the non-culprit vessel did not change from baseline to follow-up. So it's actually quite reliable, whether you do it at the time of the STEMI or you do it more than 1 month later. There was no real change in the index of microcirculatory resistance, the IMR. And so they also looked then at the FFR. And the FFR value of the non-culprit did not change between the acute and the follow-up. So no difference. And in only 2 patients, the FFR, which was positive at initial,
but
was,
here it's changing 2 patients out of 14.
Yeah,
or what?
Out of 14.
Okay.
So basically, what it was negative. I mean, it was negative FFR at the time of the infarct, but it was positive FFR at the follow-up. So that's just something to take note of.
Okay.
So maybe it is reliable in the non-culprit vessel. So what does the data tell us? So lots of trials that have actually looked at FFR in the non-culprit vessel, going back to 2015, the Dynami 3 pre-multi. This looked at 627 patients, multi-vessel disease. You had non-culprit more than 50%. And really what this showed was that FFR revascularization was better. So you had a 9% absolute reduction in MACE. Then came compare acute, which showed a similar sort of picture. So 885 patients doing culprit only versus FFR guided non-culprit complete revascularization. And again, showing that FFR guided was better. But maybe these two were just because they were actually doing complete versus incomplete revas, which is what the complete trial showed us. So more recently, the Flower MI trial looked at FFR guided versus angio guided. So complete revascularization, but one is FFR guided and one is just angio guided. And really this showed that the primary outcome was not different in both groups. So they concluded that there was no added benefit of FFR over angiography, particularly if you're doing complete revascularization.
Bharat, come back 1 second to Flower MI. Did they use a online QCA for assessing the angiographic?
They did use a core lab for the for both groups.
So this is very important. This is very important because one thing is the assessment of an interventional cardiologist just watching the angio like you showed before. The other one is to have a formal QCA assessed by an independent operator and all of that.
Yeah, so I think they are doing
the
a subgroup analysis
of this data to real life. They are not always the same.
Yeah, because there is objectivity, I think, in terms of how we interpret, just like the case earlier.
Yeah.
The other trial that kind of looked at that was 2 years ago, the Korean trial, which included both NSTEMI and STEMI. And they showed that if you did FFR guided, you actually had a better outcome. So the primary endpoint was better in the FFR guided group compared to the angio group. So a bit conflicting. But there's some notion that they basically included a lot of type 2 MIs, and so as a result, in terms of true MI patients, it was actually not that many.
Yeah.
And finally, more recently, I think we spoke about this a couple of weeks ago when we looked at the ACC trials, the full revas trial, which was recently presented at ACC. Now, this again showed that if you did FFR-guided complete revascularization compared to culprit only, there was no lower risk of the composite outcome. So a bit kind of unusual, and we talked a little bit about why this might have been unusual when we last had the discussion. So I won't spend too much time on this. So I guess the answer for question 2, FFR in the culprit artery, we know is not reliable, but may be reasonably reliable in the non-culprit. The use of routine use of FFR, there's conflicting evidence. My sort of little take on this, if the lesion is more than 70%, you probably don't need physiology, but you can consider it, particularly if you've got 50 to 69% and you know it's not really that severe, and maybe you just want to be absolutely certain. And the final sort of question here is, if we do decide to fix the non-culprit, when we should do it. And we had a little bit more of a chat about this. I think Sandeep mentioned about, decrease rehospitalization. We're able to do these patients earlier, but one of the problems with doing immediate multivessel PCI is that you have higher contrast, higher time, and also you may have complex disease that you may underestimate and then be stuck in a very complex two vessel procedure rather than just coming back, during the same hospitalization. So there are risks and benefits in both. And really this schematic kind of looks at all the different trials, comparing immediate multivessel PCI, stage multivessel PCI, and infarct-related only conservative approach. And so we know from the complete trial that doing it during the index hospitalization or within 45 days is better than not doing it at all. So I think they established that we should do it, and the timing is within 45 days. But more recently, 2 trials have looked at whether there would be any non-inferiority with doing it at the time of the initial infarct. Now, I think this can be a bit dangerous, particularly if you underestimate the disease and particularly if you have very complex lesions. So my little take on this is that we can fix it immediately or stage it, and it's best within 45 days. But use common sense. If you have complex disease, you've already used high contrast load, you have other confounding factors like patient has renal impairment or LV impairment, then it's probably best to stage once you're able to gather more information and stabilize the patient. And this little schematic here, I think, summarizes everything that we've talked about, and I'll just include that so just for completeness. In terms of future developments, there's a lot more push towards angiography-derived functional assessment now, so QFR. Prof spoke about iModern, and that's really looking at IFR-guided PCI.
Yeah, the problem with iModern is that the PI Niels had to change the primary endpoint after we have finished the enrollment. So
right, okay.
That was crazy because there were very low events. And so they decided, okay, it wouldn't have been serious to change the primary endpoint, but they decided to change it and to move it from year 1 to year 3. So this is why we finished enrollment back in 2020, end of 21 or early 22, but it will take still a bit of time before having the final answer on is it better to do an immediate FFR or an MRI or any other technique to understand if there is ischemia is better.
Yeah, and I think Wojciech really mentioned about imaging and the use of imaging to look for plaque burden and other potential sort of high-risk features. And this is, these trials are underway. We know based on the PREVENT trial that was presented also that there is some benefit with that. So it's a watch this space with regards to future development. So what is my take? In the past, I think severe 70% lesions, I would send them back home and then bring them back for a stage PCI. Now I tend to do it before I discharge them.
Okay.
If it's moderate, in the past, we used to not do it or do a stress test. And if it's positive or the patient has symptoms, then we would do it. Until recently, we used to either send them back and bring it back for a stage PCI, or do a FFR and do it before the hospital discharge. So bring them back, do a pressure wire, and then if it's positive, fix it. But nowadays, I tend to use the other sort of tools, and particularly with QFR, we use quite a bit of it. Do it at the time of the procedure, and then we plan to either do it immediately if it's not too complex, or if it's a bit more complex, then before hospital discharge. So just to conclude, what happened with patient 1? It actually ended up being quite a complex disease.
So when did you do that?
Sorry?
When did you do that? The second
Oh,
piece?
we did it before the hospital discharge. So 3 days after the initial event.
Okay.
And you can see it was quite calcified, a large ectatic vessel, definitely a step up there on the IFR. So positive IFR and a step up showing low, sort of focal disease. And so I needed to use some NC balloons and IVL, and a single stent there. And I decided to just manage the CTO medically.
The circ. Yeah. Okay. Got it.
Yeah. And so what about case 2?
So question, who was speaking? Bacchus?
Yeah.
Oh, sorry.
Perfect result. Very nicely done. The point is that sometimes we came across with such patient in which we are having a angiographically significant disease, and when we are doing FFR or IFR, we were not expecting that it will be normal, but most of the time it comes normal. So how we deal with these type of patients further? Sometimes angiographically significant disease is there. Because in my cath lab we don't have a QFR software available. So when I'm doing the FFR or IFR, it usually comes normal. After
if you don't do that, the problem is solved up front. So if you have an angiographically severe lesion, why do you do FFR?
Sometimes it is an intermediate lesion, like
intermediate is another thing. If it's intermediate FFR, you have to rely on FFR. If it's negative, you go on. My suggestion is to go with a good follow-up, because this is something that is becoming a problem due to long waiting lists. So in many centers, at least in Europe, there is not an adequate follow-up in patients after PCI, and this is becoming an issue. But you should follow up these patients. If you have a 60% stenosis, negative FFR, this patient may become a high-risk patient later, so you should follow them up.
Yeah, thank you.
Yeah, so I think this was one of the reasons why I did the IFR as well. I find sometimes with these ectatic vessels, you can get surprised when you do the imaging. It's measuring about 3.54 millimeters square, but the pressure wire is negative. So for this case, it was positive. So, we went on to fix it. And then with regards to case 2, after the PCI to the right, I actually went back and did the pressure wire. And we've continued to manage him medically. And like Professor said, we keep a close eye. In our center, we follow our patients up.
FFR is 80 here.
It's, both are borderline, isn't it? 0.8 and 0.9.
Come on, 0.8, you redo adenosine, becomes 0.78, you do it.
Yes. But quite interestingly, he was enrolled in a trial. So we actually had subsequent CTCAs at 6 weeks and at 12 months. And so this was his CTCA at 12 months. He's been free of symptoms, and the stent is patent, and the disease continues to remain moderate.
Okay.
So this is someone we do keep a close eye on, and because he's been symptom free and the CT has been reassuring, we've continued to manage medically. So some summary and take-home messages.
Another question, Bharat. This patient has 2 lesions actually. In the CT scan, you just show the proximal LAD, but not the distal one. There was also a distal lesion. If you come back to...
I might have to go back to the start, I think. I don't think I put...
There was a proximal stenosis, which was, if I remember well, not very worrying. but the distal one also was a little bit more. No, it's,
Yeah.
no, I remember it was worse. Yeah, no. Yeah.
Maybe a
So-
little bit of spasm or.
Yeah, but yeah, it makes sense having not treated that with also if the FFR was borderline. Yeah,
Yeah.
that makes sense. Yeah.
So I'll just finish off with some final take-home messages. So revascularization of non-culprit artery stenosis in STEMI patients, we know it's beneficial, and that was shown by multiple trials and the complete trial. You should consider hemodynamic assessment in moderate disease and early stage PCI if possible. And then there's now emerging data for angiographic derived functional assessment, and this is promising for the future. Thank you very much.
All right. Thanks, Bharat. You did a great job also in going deeper into it was not just an analysis of the literature, but a case-based discussion with your input. So this is the way to do this type of activities. I really appreciate what you've done.
Yeah, very nice.
Really.
Very nice, Bharat.
Thank you
I've
so
got a question
much.
to ask
Very
you.
nice.
Yeah, that's Sandeep, is it?
Yeah. So in the case number 2, you relied on invasive pressure wire than non-invasive stresses. Why? Just out of curiosity, because if this was a moderate lesion, why did you not use I don't know, perfusion MRI, which would have given you the answer? Do you rely more on a invasive FFR than a non-invasive stress testing?
Yeah, so for us, we don't really have very easy access to, actually, we don't even have MRI perfusion. So we either have a nuclear perfusion or stress echo. This pressure wire I did at the time of the PCI, so the primary PCI. So
you did at the same time. Okay.
Yeah,
okay,
so this was, I just swung back over to the, you see, it's the same guide. So I just swung back over once I finished with the PCI was very straightforward, wire, balloon, stent. And so I just swung over with the, the date is exactly the same. And just put the pressure wire down and got the reading. So this is what I wanted to show you, that maybe it's okay to do the non-culprit pressure wire. And I do both the IFR and the FFR because I think having the spot is also quite useful, particularly if you've got if you're worried that microcirculation may be clogged up. In this case, it was pure RCA infarct, and it was quite early presentation. He didn't have no reflow, so I was quite happy to just swing right over, put the pressure wire down, get my answer, and then we can plan for discharge, and we can then enroll him in our trial. So this was one of the trials that we did. So it's kind
if this was positive, would you have stented it?
I would have brought him back to stent it, yeah, or I would have done it at the time, yeah.
PCI.
Yeah.
I mean, PCI, not necessarily stent.
Yeah, PCI, that's right,
Whatever,
yeah.
angioplasty.
DCB, or I mean, it's always
And
just try with DCB, and only if you dissect, then you stent, right?
Yesterday after, let me see, for 5 years, I did another scaffold.
Oh, very nice. The magnesium one, is it?
No, I don't use it. No, it was a phantom. I did the first phantom in 2018, and which was actually my last scaffold because, you remember what happened to absorb. Then we did some Renascent, and then I did another one yesterday. It's really nice, really nice. Yeah. Let's hope.
What's your feeling with the Phantom?
No, the Phantom is good. It's interesting. The strut thickness is lower. Of course, we have to meditate on the mistakes that all of us have done with absorb. So there are, the criteria for the selection of the lesion are important. The imaging is 100%. Avoid severely calcific lesions if you don't manage them, but really strictly. So it takes time. But I think there is room today also, despite in Europe, at least we cannot use them. Well, we can use them, but we go against the guidelines because they say that you're in class 3 if you are outside of a clinical trial. But that said, in a young patient with a soft lesion, if you deal correctly with imaging, as I said, and with a good lesion preparation, I think that that's the way to go. So I'm still a believer, more skeptical now as compared to 10 years ago or 8 years ago. But it was for me exciting yesterday to do that. We did an OCT assessment, we did cutting because there was some calcification and it went well. Nice.
You did one RCA yesterday. You were mentioned in the LinkedIn address. There was dissection.
That's another case. That was a huge dissection that we left. But I will prepare a presentation and show it to you next time.
Yeah, thank you.
Very nice.